not that anti-segment surgeons, they do divide and conquer, and they always, overcome the situation. But sometimes, if situation comes like this, that even posterior segment surgeons also need to play a role of, divide and rule or divide and conquer kind of situation. So this is a story of one-eyed old gentleman. Done? This is a very old video. I mean, almost more than 10 years back.
However, we should be prepared to face them.
Sound.
Our story also begins like this. 62-year-old high myopic gentleman presented to us with traumatic subluxation of IOL, retinal detachment and choroidal detachment in his right eye. He was operated for retinal detachment surgery and choroidal drainage with silicone oil injection and had a successful post-operative period with good visual recovery. But something else was waiting for him. His vision started dropping due to corneal decompensation because of silicone oil touch. But the oil could not be removed for the risk of recurrence of retinal detachment. So we had to find a way to prevent the corneal damage while keeping the oil inside. And we came up with this innovative idea of forming a barrier. Two side ports were made. AC reformation and synecholysis was done, during which oil droplet was seen going in the vitreous cavity. A 10-0 proline suture was passed from limbus and taken out at 100-degree opposite limbus and spanned the cornea horizontally. Similarly, with another proline suture, we spanned the cornea in vertical manner. And a criss-cross mesh was formed over the iris plane. The strings should not be too loose or too tight. The final knot under limbus was buried under conjunctiva. The visco which was inside was washed and side ports hydrated. Thus, a barrier was created by weaving a mesh with 10-0 proline suture above the iris plane. This mesh compartmentalized the anterior and posterior chamber. A widthful decision can save you at that point from being drowned.
So 1
This
year later,
video thus demonstrates how this innovative method can prevent silicon oil related complications in FAQ. Thank you.
1 year later, I removed oil and the silicon mace as well, and this gentleman is still under follow-up with me and happy with FAQ glasses also.
Thank you, Rupak, for this excellent concept. In the primary surgery, was
Should be prepared to
inferior PI was done to
Yeah.
prevent the migration.
Yeah, it was actually a traumatic mydriasis because of that, so it was not there, but it was inferior PI was done.
Generally, that is the standard procedure we do to prevent the migration of silicon oil in the
So
ambient
this eye was actually acting like an aniridia eye. So because of that, but initially when we filled, it was staying there. But over a period of time, slowly the oil bubble has started moving up whenever he was, sitting position, and causing actually the residual amount of the iris was causing a iridocorneal touch. That's why the synecholysis was also done, and the IOP has started going up because of that.
Another question, like you have put a mesh. So instead of doing a mesh, because yesterday also somebody showed a similar procedure, he just put a crisscross in 4 corners.
Hmm.
So, is it good enough to prevent the oil to?
Yeah, this was long
Because
back.
it's
Actually,
a bubble. It's a single bubble. You have to prevent it.
correct. So it depends upon how big is that. It is actually there are literature report which shows that even a 12 to 16 square is more than enough to prevent it, because the silicon oil, if you have a 5,000, then even you can make a little less number. If the size of the square is sufficient enough with the surface tension to prevent it off. So probably 12 square is good enough to prevent it. 1 or 2 or crisscross may sometimes can prevent it off, but again that may be chance of luck.
It's only one situation we cannot. This condition cannot be helped. That is, if the oil is emulsified.
Yes. So then you have to take it out.
Great talk.